The term rescue task force means a lot of things to a lot of people, and sometimes they don't line up really well. But today we're going to talk about what a rescue task force is about and how to practice it in the real world. Stick around. Welcome to the Active Shooter Incident Management Podcast. My name is Bill Godfrey, your podcast host. I am joined by three of my other fellow instructors here at the National Center for Integrated Emergency Response. I got Billy Perry here to my left. Billy, good to have you back.
Good to be back, Bill.
And Chad Lake. I think that was the same seat you were in last time, Chad.
I think it was.
All right. Welcome back in.
Thank you, sir.
And Ron Ottebacker back in the house.
Thank you.
All right. So today's topic is rescue task forces, which has really kind of taken a life on its own in terms of defining it. There are some organizations that have defined it very narrowly and use it in a hyper niche way. And then there's others like us that have taken a little bit more broad term to it. So let's talk first about what a rescue task force is and its primary responsibilities, what that looks like, sounds like, feels like, and then we'll tangent into how to do some of those in real life. Sound good?
This is great.
All right. Chad, you want to lead off Rescue Task Force. What is its mission, purpose, et cetera?
Well, the Rescue Task Force has a medical element to it combined with a security detail assigned to protecting the medical element. Depending on the situation the teams bring up, we are going to be deployed into a warm zone that is already secured to go assess, triage, treat, and remove casualties.
There's a fairly concise description of what it is. It's a medical team, and the staffing on that medical team has a responsibility of doing medical work, and some of the staff have the responsibility of providing security. Billy, does that mean that they have to be 2 cops and 2 fire EMS people?
No, it does not. It means it can be fluid. It can change. I think the biggest thing that needs to be remembered is it is a medical team. It is not a hunter-killer team. It is a medical team. Now, they are there, and they do have teeth if they're engaged and or attacked or if the opportunity presents itself right there. But, we're not hamstrung or boxed into a certain number.
I like that. Ron, your thoughts on the team makeup?
Again, ideally, we like the medical component to be
medical
advanced
people?
Medical. But there may be times when it's strictly law enforcement going in as the RTF. And in that respect, the law enforcement officers assigned to the medical function of that need to understand that is their function, to render aid to people that are injured. And then they still got a security component also. The ideal thing is, and that's what we're talking about here, is practice what you're going to do in real life. And there's many opportunities to do that practicing that maybe thinking outside the box will bring it so it's a more cohesive team as we deploy them in high-risk situations.
Yeah, I think that's one of the interesting things I hear about from some folks. They feel like, oh, well, the RTF is only when you're mixing EMS people with law enforcement. If it's all law enforcement, you have to call them by a different name. You have to call them the rescue team or the go grab them and drag them team or whatever. And fundamentally, that's just not really the case.
Right.
It's we use the term task force. It comes from NIMS and ICS in the sense that it's talking about mixed discipline. And to your point, it may be 4 or 5 police officers, but some of those police officers have to be assigned to the medical duties because they're going to be carrying medical equipment, bags, dressings, airway stuff, maybe
Tourniquets.
Tourniquets, maybe drag and carry devices, things like that. But they're going to have stuff in their hands. They're not going to be on their weapons.
Right.
And it's still a mixed discipline. You got EMS discipline and protection discipline.
Right.
It's just you're still wearing the same clothing.
Right.
So in the same uniform, you're just on a different discipline.
Same costume, different job.
Absolutely.
I like it. That's a perfect way to say it. All right. So let's go through the very basics of the job of the Rescue Task Force. And let's start with the first one through the door. And along the way, let's also address the size of these task forces. So, Ron, first Rescue Task Force through the door. Big team or a small team?
I would keep it fairly small. You want to move quick. You want to, once you get in, you can assess the situation at hand. You may expand your teams coming in because you're either more sure of your warm zone being secure, or at least security elements in place. And so you may decide to expand it once you see what's at hand. But initially, I want to move quick. I want to move safely. And again, they're moving with the security component in charge of the movement. They're not in charge of the team. They're just in charge of the movement. They determine where to go. They've talked to tactical. They've talked to the contact teams. They know where it's safe to move and how it's safe to move. And then once they get in there, it becomes a medical component, and they take charge. And the security component is simply there for that. They're for security, nothing else. They don't leave their side for anything.
And Billy, that's a really good point Ron just made, is the senior medical person on the medical team is the one that's in charge of the team, but they don't get a vote in how they move or where they move. That's
correct.
That's the security team's department.
That's the security element. And the size of the team, to piggyback on what Otter's saying, the size of the team depends on what the venue is. Like if you're outside, I want bigger.
Yeah.
If you're inside, I want smaller.
Travel light and fast. Tell me why do you want the first team through the door a little bit smaller, more maneuverable?
In a building, because it's not as hard to secure a room. It's hard to secure an outside. We had a podcast about big outdoor venues.
Yes.
That's hard. And if you don't know where the shooter is, you need 360 security. When you take a room, regardless of the room, you need to cover doors.
The end. Okay.
That's it.
All right. Very good. So, and that is one of the, as we move on this, that's one of the reasons that we don't advocate, or we advocate against, I guess I should say, defining in your policy the numbers and the size of your RTF,
right?
Because your first team, from a tactical perspective or from a law enforcement security perspective, we would like them to be a little bit lighter, a little bit more maneuverable. But to your point, Ron, once that first team gets in there and sees what they've got, the second team might be a whole lot more people.
Right. More robust
with people, with equipment, things that they need to get it done.
Yes.
All the above.
Yes.
And that also allows for your follow-on responders to get there. We may be deploying the first team fairly quickly. Even a rescue task force, in my mind, needs to be deployed as quickly as possible, as safely as possible. But expanding teams after that allows for more follow-on responders to get there, maybe expand the team size and function.
Because what they gather going in there is intelligence. They know what they're walking into. They can now report back real time, boots on the ground. This is exactly what you've got. If you come here, you can do this. If you go here, you can do this.
I like it.
With the fire EMS side too, with that first team being light, is that they might be doing the initial triaging or more accurate triaging from what the contact teams pervade down through tactical. So they might want to be able to move quick to also let triage know, listen, we have this amount of injured, and this is the criticality of them. And we're going to need more tourniquets, more patient movers, whatever the case may be, to relay that information down. And if I'm overloaded with equipment, trying to do a rapid triage of what do I actually have and try to get as accurate information I can to get the resources in. And like Ron said, the resources might not even be there yet. So come prepared with it.
Right.
It's interesting. I think in a perfect world, and of course these calls never go perfectly, but in a perfect world, the contact team that's already downrange is going to get a room secured, set up as a casualty collection point, and they're going to begin assembling some of the casualties, if not all of them. And in a perfect world, that first rescue task force is moving into an established casualty collection point that has security and has the casualties assembled. In a perfect world.
In a perfect world. In an even more perfect world, the rescue task forces have worked together in the past. They actually know each other's lingo. And while the medical assets are providing triage and actual medical, the trigger pullers are not just sitting around waiting to trigger pull. They're actually looking, going, that would make a great CCP. That would make a great AEP. I could put them both there while they're doing tags and doing whatever. And then they can say, hey, they can talk to the medical component. Hey, I think we could put an ambulance exchange point and a CCP right here and coalesce Like
Exactly.
That would be the most perfect world.
It would be. And I've seen people hit that occasionally, but it is a little rare. But the idea of being a first team going through the door, you don't really know. You said you're picking up intelligence. You don't really know what they're going to see.
Right.
So Chad, in some cases, you might be dropping into a CCP that's already secured. And in some cases, you might be just getting into the vicinity of where the injured are, and you have to get a CCP sorted out.
Correct.
Yeah. And that's doable. Now, you got to be careful about having the security element of your rescue task force being responsible for the security of the CCP, because that can get a little dicey if you've got to move again, because you don't want to leave it unsecured once you've secured it, right?
Right.
So we drop in, we get that first team in. If you've got a CCP, great. If you don't, get one set. We got to get numbers out on the casualties. And what about, you mentioned earlier the severity levels and getting them out and the color codes. Talk a little bit about what those responsibilities are on that first team for getting the numbers and the triage done quickly.
Well, it's got to be accurate. And we know that a yellow can turn into a red rather quickly. Green can turn into a yellow rather quickly for not treating. Trying to get the severity out to tactical, to elite or triage, to talk to transport, to make sure that we have those resources there. Because, and the AEP, trying to find out what that is, because is it right outside of the CCP, which would be most perfect ideal situation?
Yeah.
Or are we going to have to move those severity patients down a hallway, down some stairs, out to another AEP? We're going to need people for that. Right. So obviously we want to get the reds out as fast as possible. How many reds do I have? Right. Do I have 5? Do I have 50? Right? So then do I have the resources there as well? Trying to get all that information out is super critical. And you can also use your law enforcement, because radio travel is going to be bad, your security detail to talk to tactical about that too, so that everybody's on that same page. And we can paint that most accurate picture. And as things change, you have to update. I had 10 yellows. Well, now I have 5 yellows because those yellows are now reds.
Right.
And their criticality has changed at this point.
Yeah. And I think it is important for the person that's working as the triage group supervisor and the transport group supervisor as well, tactical as well, to understand that your numbers that you got on the first radio call are probably not going to match up with the numbers and the colors of anything that happens after that.
Right. When they unkeyed the mic, they were probably different.
Yeah. Right. Well said.
Right.
Well said. So Chad described having to work a long corridor to get down to an AEP, which begs the question about cordons. And in some cases, I've seen people refer to cordons as a different tactic or needing a different group of skills. But can't a contact team or two secure a cordon and it's still the same thing?
Yes. It's sort of like a perimeter. It doesn't mean we have to be shoulder to shoulder all along there. It just means we can see each other. You can cover it with a platform, a firearms platform.
And we allow access and egress from that area.
From that area.
We're just protecting an area they're moving in.
And if you do find, like, to regress just a skosh, when you were talking about you don't want to leave a medical team for a CCP, whatever, utilize your contact teams. And you can even educate them. Is there an area that's better than this for whatever? Let them find one.
Absolutely.
Let them hold it.
Yeah.
And then communicate back and forth. Because that's the other thing with RTF. You have the medical aspect, medical branch has access to the law enforcement communications because of the security element, and vice versa. The security element has access to the medical communications because of the medical team, so you can communicate right there on the ground.
Yeah, and we didn't talk about that. It's probably important to say. When you're part of the rescue task force, you work for
Medical.
Triage.
Yeah, you work for triage.
Mm-hmm.
Who's working for medical?
For medical.
Yeah.
Right.
And but if you're the security element on that rescue task force, who are you talking to on the radio?
Tactical.
Exactly. And how come?
Because I'm still under them.
You've got to know what's going on in the
Active intelligence.
Right.
Yeah. If something changes, if something kicks off, you need to be on the line with tactical.
Immediately.
Yeah.
That's also the capabilities of your radio system, depending
Right.
on your jurisdiction. Can
Right.
law enforcement tap into
Right.
fire EMS or vice versa?
Right.
We can't tap into the law enforcement radio channel. So it's important for tactical to understand what the RTFs have.
That you got to relay that information.
Because they might need, because the RTF, law enforcement security, is, hey, I need tactical. I need maybe another contact team here to hold the
Right.
corridor,
Right.
just in case, so we can take patients out of that corridor into maybe a more secured location or a secured room.
Or to hold the room for the CCP, AEP.
Sure.
And like Billy said, it also allows, if the medical side of the RTF is up to it in alligators and they're busy and you can't raise them on the radio, you can always go to the
Tactical.
law enforcement side and have them get them on their channel, so that we've got communication. It's redundant communication.
Yeah, it's a little bit of deliberate overlap to make sure things,
Layering, if you will.
yeah, so that things flow a little bit smoother. All right, so first RTF through the door. If you don't have a casualty collection point, get your casualties assembled and get a place where you've got some security so that you can do some work. Get your initial triage done. Get your counts and your triage up to the triage group supervisor, radioed up, and request the resources that you need. Billy, you mentioned this earlier. Start talking about the AEP.
Yes.
So these are all things that should happen very, very quickly, very quickly. That quick assessment, the quick numbers, the quick count, a quick discussion about where the AEP is, and then let the security people do the security things and get the AEP taken care of, and go to work on patients.
Correct.
So we'll talk a little bit more about the second RTF coming through the door. Actually, let's go there now. So when you're the first RTF and you've done your initial triage, whether it's START or SALT or whatever method you're using, okay, great. You got 7 reds. Which red's more serious? And that comes down to medical judgment, unfortunately, because the START and other triage systems, they only get you superficially there. They don't get you
Correct.
there. And so there's some prioritization to who's the most severe red, who's the most severe yellow, who's the most severe green, and getting them organized. Because at some point when the AP does get set and you got an ambulance there, who are the first people out the door?
The most severe.
Should be the most severe.
It should be.
Should be.
It should be. But of course, if you've got one medic in the back of the rig, can they take 2 critical reds?
No.
And so that becomes part of the balancing equation, and certainly knowing your local area. So, Chad, you're inside. You're on that first RTF. You're the RTF boss in the room. You've got a sense of where your criticals are and how they're lying. Second RTF shows up. You got a little bit bigger team, right? Let's say they came with a security element of 2, but you've got 4 or 5 or 6 people that are part of the medical team. What's your direction to them going to be?
Do we have an AEP set up or not? Because if we have an AEP set up, I can use that second RTF team to start transporting those people down to that AEP and moving them. Hopefully that second RTF team brought in extra equipment if I gave them that.
Right.
Because how much equipment did I have? How many tourniquets do I have? How many, bandages and gauzes? Obviously I'm not coming in with cardiac monitors, but how much of the stop the bleed stuff do I need? So they're bringing in that stuff. So then we can start doing that indirect treatment to hopefully prolong further criticality. But that second RTF team's coming in with extra equipment. Obviously, I have extra hands. And then if I have that AEP set up, take the critical, let them get them going. And that's going to be that direct correlation between triage and transport, making sure that I have that constant flow of transport units if I do have it. If I don't, then I'm going to have to hold back and start treating and hopefully prolonging the dying.
Right.
Yeah, I mean, at the end of the day, if your second RTF through the door is actually fairly quick, Johnny on the spot coming in behind you, you may not even have finished assessing patients. You may say, hey,
This is where I stopped.
this is where I stopped. I need you to grab those 3 in the corner.
Right.
Or if you've gotten a pretty good first pass, you may be able to say, those 2 over there are the most serious.
They need to go.
Get them,
Right.
get them do whatever treatment you've got, and get them ready to go out the door.
Right.
And then maybe the third RTF is the one that shuttles the bodies.
Could be shuttling.
And you just keep working it. Now, what is different when you end up with more than one casualty collection point? How does that complicate things for the rescue task forces?
You need to coordinate between the two casualty collection points and try and make a determination who's more serious, and that would also require extra RTFs to manage the two areas, plus get other resources in to help them move patients to AEP when we determine it's time.
Plus other contact teams for security, for us.
And making sure everybody's aware of the labeling of it.
Of
You
where
can't say
everything is.
Tell me
casualty
more
collection.
about that.
We can't say, all right, we're casualty collection point 1, casualty collection point 2. Well, where's 1 and 2 at? Maybe give it a room number if you're in a school.
Right.
Casualty collection point, room 103. Casualty collection point, library. North side, south side. North's up for me, south is down, right? So be careful. Make sure everybody's on the same page. RTF 4, I need you to report to casualty collection point at the library.
Right.
And
More
make sure
importantly, you
everybody
can't just say
understands that.
the casualty collection point. You can't just say the CCP, because it'd be like, we emptied the CCP.
Right. I'm here.
There's,
Yeah.
Right, but there's 2 of them or 3 and that's reality.
And that's going to happen with your AEPs as well.
100%.
And Billy, I know you've been as Ron has as well, then the coach at the tactical position during training. When they get to these more complex scenarios where there's 2 or sometimes 3 casualty collection points, how much does that increase the difficulty level for tactical and the triage group supervisors?
If they're unorganized, exponentially. If they're organized and stay on top of it and press discipline, then not as bad, not near as bad. Still
Suboptimal, but not
suboptimal, but
not a complete train wreck.
Right, but not insurmountable. Yeah.
Okay. All right. Very good. So I think that kind of covers the basics. So it's essentially rinse and repeat.
Right.
From there on out. The casualties all need to go. Don't get wrapped around the axle about the numbers. Make sure that you're using some medical judgment to assess of your 7 reds, which one needs to go first, second, and third. So now let's switch gears and talk a little bit about opportunities in the real world to practice rescue task force skill sets not used on an active shooter call. So what are some of the events that you think are opportunities to exercise the rescue task forces?
We use them at football games.
Okay, tell me more.
We incorporate rescue task forces at all the Jaguar games, Florida, Georgia, anything that's a big venue like that. We deploy rescue task forces.
And how does that work out? How does it go over? What's the goodness of doing all that?
The goodness is, and you've heard me say it before, you do not want your first time doing anything the first day of the big game. You don't want the Super Bowl to be, not literally the Super Bowl, but you don't want your big, this is it, this is the call. The first time you ever did a rescue task force, a breach, or whatever, you don't want that to be that day. You want to be well-versed in it. And this is where everybody needs to become familiar with each other.
Okay. Ron, you got any eyes?
I think you do it anytime you've got a deployment of fire personnel and law enforcement personnel. If they've got a drunk in a crowd of people, law enforcement is going to respond, fire is going to respond. Why don't they respond together? It gives them the opportunity to work together, understand what each other's doing, get to know each other.
And each other's tactics.
Right. And practice moving as a team.
It builds comfort and confidence.
It also helps familiarize you with people on the other side that you otherwise haven't met, haven't talked to.
True. And
gives you a chance to learn each other's lingo.
100%. And comfortable with the tactics. And like it or not, it's better optics.
Yeah. And I like to establish that relationship before. Let me know your name. And then what are your expectations of me from law enforcement to the fire side? What happens if things go south? So things present itself right now and we need to take cover or we need to retreat. What is that? What are your expectations of me? And then what are my expectations of you? If we have to treat people in a probably comfortable spot, like a corridor that's not super secured, you say, hey, you have 30 seconds. I need 2 minutes. I have 15 people down. I can't just grab and go type of thing. So, and we need to have those conversations again before the big game.
Right.
Yeah. Yeah, and Billy, you mentioned doing that at games. Does this apply to all pre-planned events? I mean, Chad, could you see? You've got an outdoor concert. You've got
100%.
the county fair.
Yes.
You've got
Yes.
The big graduation ceremony, and it's going to bring in 10,000 people.
The big concert, both inside and outside.
Yes,
Right, the big
inside and
venues,
outside
multiple
venues.
Yes.
Does it make sense to do an IEP and actually structure the rescue task force and those teams ahead of time?
Yes.
Absolutely.
100%.
Absolutely. And then the big conventions that we have, around, especially in, Central Florida, we have MegaCon, Comic-Con,
Right.
presidential details. I mean, we do have to get together and, again, pre-plan that and train. And we can do mock scenarios. We can do mock exercises, and just on every command staff of it, we don't have to do a one full blown out drill every single time. We can do just an RTF drill, a contact team drill. And when you do a contact team, obviously that's law enforcement, but bring the fire side in there so we can understand what the contact teams or the contact teams understand what the RTFs responsibilities and what that movement and what that working together as a team look like.
I think the bigger question is, does it make sense not to do it?
That's a good point.
It's an opportunity for us to work together. It's far harder to tell a friend no than it is to tell someone you don't know at all. So by those relationships you build and having an understanding what the needs are, then you said, yeah, this is an easy thing. Let's do it. And it's going to serve both sides of it. Well, all three sides of it, because it's going to serve the community well too.
Right. And assuming that each other, to go back to what Chad said, assuming that each other knows what the other's jobs and responsibility is ridiculous. That's something that has to be established early. And I think even if you can't do it on a patrol level, I think if your jurisdiction is of the size, let your specialized teams train, interact, wherever it is, mobile field force, let them interact. So at least they get to know each other. They get to know the lingo, and you can talk about how we're going to do this. This is what I'm going to do. This is when I say this is what I mean. When you say this is what, you know what I mean?
I do.
So
I do. And I would say from my perspective, I think it's a great opportunity to have conversations about things that otherwise might not come up. For example, and I say this in training a lot to law enforcement officers, never assume that the fire and EMS people that you've been assigned to as your rescue task force know jack about operating in a tactical environment.
Correct.
Absolutely.
I found out all kinds of, by attending some contact team training, I found out all kinds of things about how to move a little bit more deliberately that keeps me a little safer. Some of the terminology, some of the things to watch out for. I learned what the X was and why it was important
to not be on it.
To not be on it. That stuff is foreign really to the fire and EMS side.
Right.
And so I think those are great things for law enforcement to take an opportunity and talk about that. And I think on the medical side, and Chad, I'll come to you after this. On the medical side, I think the thing that I would want to say to law enforcement officers is, look, we are in a hurry and we are up against the clock, but not everybody's up against the same clock. Right. The person that's been shot in the leg, that's got a tourniquet on, the tourniquet has absolutely controlled, if not stopped the bleeding, is a much lower priority than the guy that's taken a round to the chest.
Correct.
Right.
Or that's got a round in the belly and is shocky. Even though the leg wound is screaming, and the other guy is quiet. And so there's these subtleties in the medical prioritization. And while we appreciate the help of well, let's just grab him and get out of here. Okay, let's grab this guy that took two rounds to the chest, and let's get him first, because the guy that you're about to drag out can wait.
Yes.
And what are the other things that pop in your mind, Chad, that would be helpful for law enforcement to know that is not terribly obvious on the fire EMS side? Well,
sometimes like you said, the gunshot to the leg, that screaming, that's good. You're screaming.
Right.
I know you're breathing. It's the gunshot to the abdomen or the chest that they're not moving. that like, oh, well, you know, he's fine. He's comfortable. He's just taking a nap. No,
He's
like
getting cyanotic.
right. Like that blue isn't makeup. Right. So let's address that. And
It's what the FBI calls a clue.
right. So trying to incorporate that into getting law enforcement to realize some of that stuff. And again, I might have to bypass some of those screaming injuries to get to the ones that aren't screaming. And do they understand that? Because, you know, you don't nobody likes hearing somebody scream. They want to, hey, get that annoyance out of there. And that's relationships. Right. It's like, listen, maybe you can talk to them and I can go address some of the more seriousness.
Right.
And trying to get that. But the only way that can happen is if you train together and you build those relationships up.
Yeah, completely agreed. The tendency to want to get them out. I certainly understand that, and we want to get them out. But if you've got a patient that's taken a round or two to the chest and you're seeing some signs that this is either a sucking chest wound or maybe a very unstable pneumo or maybe a hemopneumo, you might want to get a chest seal on it. And if you've got, and that's a right now problem if you're starting to see some indications that it's sucking. And likewise, if you see signs of a tension pneumo, that's a super right now problem.
Right.
And it means that we need to decompress it because they're not going to last very long unless we stabilize that. But those kinds of things, I think they don't happen often.
No.
Right.
They're the exception, not the rule. And so sometimes we forget about that in our race to the clock. But I think the thing to remember is not everybody's on the same clock.
Right.
We got to get the critical ones out first.
And I think doing some of that medical training with law enforcement, do you know what a sucking chest wound looks like? Do you know what a tension pneumo looks like? What are some signs? Because maybe you have a contact team or part of law enforcement maybe helping you maybe triage if possible. If you have the extra hands and resources and security is taken care of, maybe they can help you, especially if you have a lot of patients down and you're still waiting on your extra RTFs to come in, your extra resources. Only a couple of people, you can only do so much with what you have. So maybe they can kind of help you. Hey, this person needs some help now and I don't know how to fix it. Can you fix it? You know?
Very good. Well, gentlemen, thank you for a great engagement on this topic. And for those of you that are listening, if you're struggling with some rescue task force issues, you've got some policy concerns, some questions, things like that, please reach out to us. We're happy to help. You can leave us a comment on YouTube or on the podcast feed. You can send us an email at info@c3pathways.com or just pick up the phone and give us a call. We're happy to help. Thank you to our producer, Carla Torres. And until next time, stay safe.